I'd like to start by thanking you for having me. I have no problem. My French is terrible. I can read and write a little, but if something is unclear, please don't hesitate to interrupt and ask me. But I am hard of hearing, and I only see so far. So if you ask me, I tend to walk towards you and stare at you to read your lips. So yeah, I don't mind being interrupted, but just realize I'll probably walk towards you if you ask me a question. I also want to acknowledge my collaborator, Dr. Christy Scott. The work that I'm going to present today is really both of our work, and it really builds on a lot of things that she's done, and much of it was funded by the National Institute on Drug Abuse in the United States. So today, my goal is to review for you some of the evolution of the general and acute care and chronic care model and their implications for substance use treatment, to highlight recent evidence on the chronicity. You saw a couple of in the slides, the stories of individuals. I'm going to show you data that really supports what the stories they were telling were, and show you some of the evidence from brain slides to epidemiological studies that all paint a consistent picture of chronicity. I'm going to try to discuss the development of some chronic care models where we've actually tested them in randomized trials with substance users and show that when you do what you do with every other chronic condition, it actually makes it work better. And that this is not just some problem that we're defining, we're actually talking about how do we make a difference. So let's start with the first part. Much of our modern medical system, including mental health and substance use, was designed to respond in the 1900s to infectious diseases. They were killing about 20% of the people were from chronic deaths. About 60% of the deaths that were happening at the turn of the last century were from infectious diseases and injuries. So when you look at our modern medical system, it's really designed to stop that loss of life from infection and from injury. The high incidence of infectious disease drove the way that various systems evolved. So the intake into a healthcare, the way doctors see you, they try to get real quickly to it and triage and try some basic things. The cares were organized around an episodic relationship in which I come in, I see you, I treat you, and you expect to be cured. Maybe we have a little bit of follow-up in 2 weeks, but that's pretty much it. This pattern produced expectations by the patients, the service providers, and policymakers of cures. It's supposed to have quick fixes. I set your arm, and it may take 6 to 8 weeks, but I want to see that cast off, and I want to see you return to full mobility with your arm if you break your arm. Okay? Very rapid cycles. The problem is that over the past decade, acute care models and advances in care have radically changed what's needed. The world is not the same as it was 120 years ago. In the U.S., chronic care conditions now account for 70 to 80% of the deaths. They've gone from 20 to 80. So chronic care is now, we don't die generally from opportunistic infections or trauma unless it's very, very severe. So now more and more people die from chronic conditions. They also account for about 70% of the healthcare costs. So when healthcare costs are going out of control, that's being driven not by that nice opportunistic infection disease system, but by chronic care. Research has shown that improving the ways in which we manage these conditions reduce their severity, the likelihood of death, and costs. So given that that's the leading causes of death and the leading costs, if you want to reduce those things further, you really have to focus on improving chronic care models. Substance use disorder treatment has historically been organized around a single episode of care. You come in, patients, when they finish treatment, we don't say it this way, but it's like we're acting like they're cured. There's minimal and rapid assessment up front, and the focus is on a core treatment to get you to stop. And it's like the sun will come out and shine tomorrow if you just stop, and everything will be fine. Well, it doesn't really work like that. But the system is set up as though that was kind of the implicit underlying assumption. In reality, even though coming out of residential or high-end treatment, we all expect there to be a step down. Not just throw them back into the community, but have them re-enter through a reintegration process. Only about 17% in the U.S. of the people coming out of residential treatment start any kind of step down. So it's not really happening. The evaluation of outcomes in research, and this isn't just treatment, the research on treatment overwhelmingly focuses on 6 to 12-month outcomes, very short term. And as you'll see in a minute, we're talking about a phenomena over decades that we're studying in 6-month increments. And usually the same 6 months, not the full course. Relapse is interpreted as failure when if you have a chronic condition, relapse is expected. Relapse, the risk of relapse is the very nature of saying it's a chronic condition. They're confirming their diagnosis. And yet we think it's a failure. Instead of saying, okay, how do we minimize it? How do we address it? How do we re-intervene right away? And those are some of the problems with the current system. Evidence from both clinical experience and longitudinal research suggests that prolonged substance use alters the brain. You can see physical changes in the brain. That the risk and progression of substance use disorders are related to the stage of brain development. If you use when you're an adolescent, it has much greater damage than when you start using as an adult. For many, it takes years or even decades for you to recover from that initial period of use. The progress of many patients is not linear. It's not like they get better and that's it. They cycle in and out and in and out, and they go through several steps. The progress of many patients, and if they don't do that, it often results in permanent disability or death if they don't succeed. In the U.S., there are estimated to be 20 million people, or about 9%, with a substance use disorder, and 58 million with a mental health disorder, including about 6% with both. Now, I want to point this out to you. It's not symmetrical. Of the people with substance use disorders, 2/3 have a mental disorder. Of the people with mental disorders, only about 25% have a substance use disorder. So there's this inconsistency when we talk across the fields. Everybody sees the overlap, but they don't actually see the same size of the problem. In substance use, it's huge. It's an elephant in the room that we are increasingly talking about. Substance use and mental health disorders are two of the nation's most costly health problems in terms of dollars and disability-adjusted life years. Worldwide, the World Health Organization estimated that in disability-adjusted life years, years where you're living with a disability, substance use and mental health together are the largest single source of disability-adjusted life years. So let me show you some pictures now to help make these points I just said in words. This is a brain slide from a PET scan. The colors, as you get lighter in color, that's more brain activity. When you go, this is showing you what happens when you get high from cocaine. In the first row, you can see the brain is red. It's kind of normal level of activity. And as you move to the right, it gets brighter. That's someone getting high. It's enjoyable. For your brain to warm up is pleasant. You enjoy that. At the bottom, though, is the crash. And as it goes dark, as you move to the bottom right-hand corner, that brain is now below normal in activity. That is unpleasant. No one likes this. And this is why people will go into a run on cocaine, because when they get there, they're trying to dig their way back out. And they know that the drug will bring them up high again, back to normal. But it's a losing game, because the more they take, the further they'll crash. So they can never get back to normal by taking drugs. They just will go up and then crash even further. That's the short-term cycle. Now, many of you may have never looked at it, but this is the long-term cycle. This same kind of technology. I'm using PET scans to look at sugar level activity in the brain. Brighter colors are more activity. The first row shows you what normal brains look. Here's 3 different normal brains showing you what kind of activity you hopefully have in the room today. This is 10 days after stopping use. That chronic pattern I just showed you, it hasn't even come back after 10 days of abstinence. The brain is still way below normal in activity. This is 100 days after abstinence. The brain is only halfway back. So when we talk about you need to stay in treatment for at least 90 days, go to meetings 90 days, it takes a while, it's not going to change in 1 month of abstinence. That's real. That's not something we made up. That's literally the brain has a chemical injury and it has to heal. It needs time. And it's only halfway back after 100 days. Okay? And that's why we need longer-term care models. Now, I'm not going to use any Latin or French, but these are the parts of the brain. And adolescence is the 3rd period of brain development, of major brain development. It starts in the middle, goes around the back and to the front. The first thing that happens a little bit before age 15 is the development of a heightened sense of pain and pleasure. If any of you have survived teenagers, this is the whiny teenager stage. I want, I can't stand this, I can't stand that. Okay? And as you move to the back, their vision improves. They start noticing things. They're seeking sensations. They're starting to move around and become more mobile. And it's no surprise to any of you who have survived adult children, the last thing that develops is judgment. That's age 25, by the way. Biological adolescence is 15 to 25. It's not 10 to 18. Okay? So this is the process that's undergoing. Now, when you look at epidemiological data, this is looking at the rates of substance use disorders in brown and then heavy use in orange by age. And what you can see is that between 12 and 20, over 90% of the use and problems start under the age of 20. Over 90% meet criteria by age 20. They get better. But that right side is in decades. Takes a long time to get better. And the reason why we care so much from a public health perspective, not just as parents, is that if you have a substance use disorder, on average you die 22 years earlier. And you typically do not go gracefully. You will have lots of hospitalization, emergency room, other medical conditions and things. You act like you're 20 years older than you are. You have burned out part of your body. If I look at people entering treatment from the years from their first use at 0 to the first year in which they achieved a year or more of abstinence or died, it takes an average 27 years before 50% of them stop. 2/3 do stop. That is the highest rate of recovery of any major mental health disorder. The only thing that comes close is ADHD. 2/3 of people who have ever met criteria for substance use disorder are in remission and have no symptoms in the past year. It works. It just doesn't tend to work in 6 months or without any relapse and back and forth. It turns out it's also predictable. When I separate out this course over decades by age of first use, when you use under the age of 15 years old, on average you will use 60% years longer in decades. Okay? So age of first use prevention messages matter because delaying onset has very different consequences on brain development and brain injury. Here's the really good news. If I look at how long from your first use to when I get you in treatment, if I get you in treatment in the first 9 years of your use, basically adolescents and young adults, right? I cut how many years you use by 57%. This is in decades. Okay? So, like every other chronic condition, early detection and intervention is a good thing to do. As I mentioned, people cycle. They don't just get better overnight. They tend to cycle between 4 states: using in the community, recovery, incarceration, and treatment. This is showing actual data from year to year and the change from the beginning to the end of the year. On a yearly basis, in this treatment sample, about half the people change between one of these states, and they move in every possible direction. There's not one pathway, there's many pathways. The probability between 2 of these states is not the same in different directions. So more people come out of incarceration and relapse than get caught using and go into incarceration during the course of the year. Treatment is not a panacea. It doesn't solve all your problems, but it is the most likely pathway for you to transition into recovery. But it's better than that, because it turns out that I can actually predict the movement. The movement's not random. There are things that matter. So for instance, if I predict who goes from using in the community to recovery, the more mental distress you have and the more legal involvement, the less likely you are to go. If you're using and you have those things, it's bad. The more you were older at first use, if you're homeless, if you have sober friends, and if you get treatment during the year, that increases your likelihood of moving over. If I say who goes from recovery to relapse, the times in treatment, so treatment in the short run matters, but if I go back to treatment 1 time, 2 times, 5 times, 15 times, if I've been to treatment 15 times, do you think that there's a good chance I'm going to relapse again? Probably. So just like cancer, if I've had 15 episodes of cancer, 15 episodes of any other chronic condition, the more times I've gone to treatment and keep relapsing is actually a negative factor. Homelessness, number of arrests are both negative. Female, the legal involvement, sober friends, and number of self-help sessions predicts staying in recovery. But think about this now. Homelessness predicts change, but not the direction. If I am homeless, if I'm using in the community and I'm homeless, it helps motivate me to get out. But if I'm in recovery and I become homeless, it's likely to make me relapse. If I'm using and in legal trouble, I tend to actually keep using. But if I'm in recovery and being monitored by the legal system, it often keeps me in recovery. So some things predict change or stability, but not direction. Other things, like treatment, predicts the transition to recovery, but not who stays there. Self-help does not predict who starts recovery, but it does predict who stays there. They literally work on different parts of the cycle. Okay? So after initial treatment, the reality is that relapse is common. It's more likely for those who are younger, have multiple treatment episodes, and more mental health or issues or pain. Those are reasons, including after trauma, psychological pain. There are reasons people use to help escape pain. On average, it takes 3 to 4 treatment admissions over 9 years before 50% of a treatment sample will reach recovery. So literally half the people are not just 2, but 3 or 4 treatment episodes. The idea of the single episode is really off relative to how people are getting better. 2/3 do eventually achieve abstinence, and treatment who predicts receiving abstinence but not who sustains it. And then, as I mentioned, self-help predicts who sustains it but not who starts it. If I look at the duration of abstinence, how long your abstinence, it turns out that recovery is not as simple as abstinence. So this along the bottom is how many years they've been abstinent. In the first 12 months, about 2/3 will relapse. So in that, if I'm absent 1, 2, 3, 11 months, 12 months, about 2/3 will relapse. After 1 to 3 years, about 1/3 will relapse. After 4 to 7 years, about 14% will relapse. But even after 7 years, still 14% relapse. So the risk never goes to 0. But it is definitely time-related. There are differences between early recovery in abstinence and late recovery in abstinence. And this is now taking that same duration of abstinence and showing that it doesn't look the same as you move along the course of it. In the first 12 months, you start seeing life changes like more clean and sober friends, less illegal activity, incarceration, less homelessness, violence, and victimization in their life. You see less use of others at home. The people they're living with and working with and where they spend their time are less likely to use. You see those changes start. When you go out to 1 to 3, there's virtually no more illegal activity or illegal income. It stopped. But it didn't stop the day they became abstinent. It took a while. They had to disengage over time. But by 1 to 3 years, it's gone. Better housing and living situations, virtually no homelessness at this point, increasing employment and income. At 4 to 7 years out, you tend to see more social and spiritual support. Often a spiritual epiphany will happen in a later stage of recovery. You'll see better mental health. Their mental health, by the way, when they first stop using, often gets worse because they were using it, substance use, to block out mental health problems. So when they stop using substance use, initially their mental health gets worse. But by 4 to 7 years in recovery, their mental health is better than it's ever been. Their housing and living situations continue to improve. Dramatic rise in employment and drop in people living below the poverty line. So in the U.S., we go from 80% below the poverty line while they're using to 20% below the poverty line when they're 4 to 7 years out. So you can see these changes. And this is what we're studying with 6-month outcome studies, post-treatment. We don't even see this. And yet we expect all those changes almost starting the day they walk into the door to treatment. Not really realistic. If I look at death, and I look at the rate of death in the next 12 months, for a matched sample of adult, primarily African American, half women, half male, in their mid-30s and 40s, about 4.5% will die in the next 12 months. Those who are using or in their first year of recovery are about 2.87 times more likely to die in the next 12 months. That risk of death goes up when you first stop, not down. Because often it's motivated by a short-term sense of risk or health or something like that. But I've just collapsed them here. As you go out in years, though, the risk of death goes down dramatically. And it actually takes about 4 years, 3 years of abstinence, which is the new DSM-5 criteria for sustained recovery, in part based on this article, that really your risk of death goes back to community normal levels after about 3 years of abstinence. So the third part here is I want to talk about translating this into an intervention you can actually do and test. What are some simple examples? So, long-term management of chronic conditions, across many different conditions, there are some common features. Proactive, ongoing patient monitoring via regular checkups. If you had diabetes, heart disease, hypertension, you would be scheduled for visits and checkups. Screening patients for early evidence of problems systematically. Motivating people to initiate and maintain change in their lives. We recognize it's not easy. Okay? If you have diabetes, I try to get you to monitor your blood sugar, and I try to get you to control your carbohydrates, right? Whatever your disease condition is, we're trying to maintain change. We have to negotiate access to formal care and removing potential barriers. If you have cystic fibrosis and you don't have the right equipment, it's hard for you to do the treatment. I may have to help you access those things. If you have diabetes and you don't have a little glucose monitor, I may have to help you negotiate access to those things. Same thing with substance use treatment. Emphasizing early formal reintervention whenever possible, when a problem arises, is again a core feature of these chronic care models. For substance use, we have some different challenges. The substance use lifestyle often leads to chaotic living arrangements. I've burned my bridges. People no longer want anything to do with me because I've stolen from them, I've embarrassed them, I've done things. I'm not where I used to be. Over time, that leads to a high rate of social isolation. High rates of multimorbidity, that is health problems, psychiatric illness, criminal justice involvement, homelessness, unemployment. It's not that they have to be related, but the more of those things you have, the harder it is for you to transition to and stay in recovery. They get in your way. They make it more difficult. Friends, family, and systems of care often view your relapse as a failing. If you relapse, it's your fault. You failed. Okay? Low rates of insurance, personal resources, and social support create barriers to recovery because the finances are not often there. The components of this recovery management checkup model, RMC, address the duration and chronic nature of substance use disorders by trying to institute quarterly checkups. So we have people come back once a quarter. We utilize a proactive approach to helping participants see how their problems are related to their substance use, to negotiate access to treatment and get them in. We offer the opportunity for multiple episodes of care in the context of this model, and we provide retention engagement. We don't believe getting you to the door of treatment is enough. You have to stay. We have to get you to the handoff to work well before treatment has any effect. The research interviews are done. We do a 20-minute assessment to determine if you need treatment. The questions that we use to do this are pretty simple. If you've got more than 13 days of alcohol or drug use in the past 90 days, if you're getting high or drunk for most of any of the days, if you had an episode of not just a sip but a binge that lasted most of the day, if it's interfering with your responsibilities or you have past month use or symptoms, so if it's even more recent and it just happened, or if you self-report a sense of needing to return to treatment to avoid relapse. We believe in relapse prevention. We don't need you to use again to say you need help. So if you need help, if you're saying I need a booster, I need moral support, I need help, we would try to get you into something. If they're already in treatment, we're not going to try to refer them to treatment. If they're incarcerated, there is either is or isn't treatment where they are. We can't control it, so we sort of exclude that one. For individuals in need, a linkage manager meets with them and uses a classic technique that many of you are familiar with, motivational interviewing. We use it to try to provide feedback regarding their current substance use and problems and how they're related, to discuss the implications of managing their chronic condition to achieve what they want to achieve. We discuss the barriers that have kept them from going to treatment. Most of them have been in treatment before, and we find out what they liked or didn't like or why they're not considering yet. And it may be purely pragmatic, like I'm an opioid user and I'm afraid of withdrawal. It's painful. I don't want to do it. I'm afraid of it. And they don't know about Suboxone. So I'm going to talk to them about talking to the doctor about getting medication to get past the withdrawal. Maybe my motivation for recovery is to take care of I'm 65 and I'm taking care of my 85-year-old father, and I don't want to go back to treatment because I don't have anyone to take care of him and he needs me. But I went to my daughter's wedding. These are all real cases, by the way. I went to my daughter's weddings and then when they toasted, I took a sip. But now I can't stop thinking about it. And I'm afraid I'm going to relapse. But I can't go back to residential treatment because there's no one to take care of my father. Well, you don't have to go to residential treatment. You go to outpatient. We can have you just sit down and talk with somebody and connect them back to support groups or stuff, right? So whatever the barriers, many of them are perceived. Another one, and then when they get there, we will do the motivation for treatment, but a lot of what we do is more addressing what their concerns are, what their barriers are. We also don't let them we ask that before they discharge them from treatment, that they call us and see what we can do. Sometimes we can block them. A classic one, a woman showed up at residential treatment and she didn't know she had to share a room and she didn't bring any pajama bottoms. So we go get her some pajama bottoms and she stays. This doesn't seem like a reason to leave treatment, right? Another one, guy got a script for Suboxone. He's starting to feel pain. He wants it. Nurse says, a night shift nurse says, nope, you got to wait. You're not suffering enough. That's not what the clinician who prescribed the medication meant. So we call him up, and it's 11 o'clock at night. He calls the nurse and said it's his PRN, not your PRN. You have to let him take it. Kept him in treatment. Now that sounds, it's more like a omnibudsman. A Scandinavian word. We're not just advocating for them, we're trying to negotiate and find some balance between the system and the person. We schedule appointments for treatment in the next quarterly checkup. We take the patients to treatment. We don't say, here's a card, go over there. We take them. If they want, we will take them the same day. We've negotiated same-day access. Or usually they have to get their affairs in order and we'll take them the next day. We will go get them, we will take them, we will stay there with them. We will stay in contact with them every day for 2 weeks. Because it turns out that if I show up at the treatment door and leave and don't come back, that I don't get better. It only matters if I engage. Once they've got them in treatment 10 to 14 days, treatment effects start to set in. Treatment grabs them, they understand them, they'll get them. But that first 10 days, there's such a high dropout rate. And it actually makes them harder to treat later if we blow that. So we stay in contact with them every day for 2 weeks to make sure that they're in. We also, when we come back after 90 days, we're always checking, how's it going? Did it work? What do you need? Did you do what they ask you to do for continuing care? Are you doing it? Do you need help doing it? So we also stay involved in them on a quarterly schedule. So let's look at what happens when we do this. This is actually from a published article that's at the end of your handouts as the references. We recruited 446 adults from community-based treatment in Chicago. It's about 92% of the program's intake, so it's a pretty high participation rate. So this is a general treatment program, has full continuum of care, and sees everybody on the near west side of Chicago. We randomly assign half to a control group that just got quarterly interviews. The other half got quarterly interviews and recovery management checkups. We completed quarterly follow-ups for 4 years with 95% or more having every wave, and 90% had every single one of the 16 follow-up waves. So a very high completion rate. We had a wide range of measures, including the gain, which many of you use, but we also had a variety of other measures as well. The biggest proximal outcome, the thing we're trying to cause a short-term change in, is to reduce the time from relapse to readmission, increase the amount of treatment they get, and reduce their substantive sitting out there in the community using. We want to break the cycle of just sitting out there. Obviously, we think if we can achieve these treatment outcomes, we want to reduce substance use, reduce substance problems, and HIV risk behaviors. So we're trying to do those things. The treatment agency is the largest provider. They do 12,000 admissions a year. Chicago's a big city, and this is the biggest provider in Illinois. They operate 28 different treatment units. So we recruited those 448 people in 6 weeks. 6 weeks, yeah. So when you guys all talk about how hard it is to do gains, we did 448 in 6 weeks. Once we did 228 in a week. So yeah, I understand. No gain, no pain, but Anyways, so full continuum of care, including outpatient, intensive outpatient, residential, and detox. There are specialized women for women and their children, pregnant women, adolescents, a wide range of ancillary services. So this is a modern treatment agency, big agency that you would see in a big city. It's certified Medicaid provider, CARF, they meet accreditation standards. This is a big, large professional program. The sample, probably fairly different than what some of you see, was predominantly African American, 30 to 49, predominantly male, but almost split half and half between male and female. About a third of them were criminal justice involved. The vast majority met past year criteria for dependence. Most had been in treatment before. About 40% had been in treatment 2 or more times before. So this is a real cross-section of chronicity in people at higher end. This is not, we didn't cream, this is not low severity people. These are really the kinds of people you'd see. Lots of other HIV risk behaviors. Some needle use, but a lot more sexual risk there and victimization. Well, a little over half have other mental health disorders in the past year. Over half have past year illegal activity. Our hypotheses are that a random assignment to RMC, those clients will return to treatment sooner, receive more treatment, reduce their quarters of need in the community, and increase their days abstinence. We think that doing these things will lead to the other changes. So I'm just going to focus on those first couple hypotheses. So this graph along the bottom shows you the months from their first time where we found them in the community relapse to when they showed up, when they returned to treatment. So we want to identify and reduce the time to return to treatment. Over 45 months, we reduced it by 32 months, the time from relapse to readmission. Instead of waiting for them by going and checking them every quarter, 32 out of 45 months we could reduce the time from relapse to readmission. That's pretty big. That works like every other chronic condition. Better still, it wasn't just about a one-time check. Every quarter we went back, the size of that effect got bigger. So it kept getting bigger and bigger every year. The control group never caught up. There's at the end of the 4 years, it's 70% return. These are only the people in need. Of the people in need, 70% return for the control group experimental and 51% for the control. So it turns out that rather than waiting for them to crash and burn and crawl back to you, the checking in with them and helping them works. It reduces the time. It helps, especially when you realize how complicated their lives are. When I do that, I can look at it other ways. The times they re-entered treatment. They're more like they entered treatment more times. They had more quarters where they were in treatment for 2 or more weeks. They had more months of treatment over the 4 years. So we wanted to not only get them back to treatment, we wanted them to engage in it and stay in it and get more treatment. Turns out it worked. If I look at how that affected behaviors, we have much shorter runs. I cut the quarters in need from 8.9 to 7.6, how long they sit out there. I want you to think about this for a second. Even though we reduced the time from relapse to readmission, at any given point in time, when someone was using and we wanted them to go back to treatment, we only could get 38% to go. And if you wouldn't go back to treatment, we'd try to get you to go engage in self-help. If you wouldn't do that, we'd try to get you to engage in a behavior change. If you wouldn't do that, we'd say, okay, but if you change your mind, call us. And let's schedule your next quarterly checkup. And in the next quarter, we'd repeat it. And likely, they didn't change. Sometimes it took 7 times of doing that before they would go. It's not like we have a magic wand and said, you should go to treatment, and they went. We had to work it for some of them. You know, we had to keep coming back and be tenacious and persistent to achieve that effect. Okay? So sometimes, I don't want to imply it's really easy. If you had just called them and asked, they would have gone. We had to work hard to get them to come back in many cases. You can see that this is total quarters in need. This is the run of quarters. So they reduced the longest run they had from 7.5 to 5.9 quarters. If I look at the number of 11 substance use problems, remember in the GAIN, the S9, if I reduce the number of problems per month, symptoms of substance use disorders, you can see that I've cut it by about a third, the average number of months. And if I look at the very last month, at the end of 4 years, you can see that we've cut it again by over a third, from 2.3 problems to 1.4. I can also see it in increased days of abstinence. It's even among the people using in the community, there are days when there are abstinence. So you see an effect, but there are still actually days, even among users, when they're not using. So these are actually significant effects. If I go back and I look at that cycle, but now I'm using the same states, but I'm now looking every quarter, every 90 days, how often do they change? Turns out that every quarter they were changing status 34% of the time. From the beginning to the end of the quarter, a third of them would change status. Again, treatment was the most likely pathway to go from beginning the quarter in treatment to end up in recovery. I can predict who goes from community to treatment, and the more they used, if they were in self-help, if they got prior weeks of treatment, desire for help, all predicted movement, and treatment resistance predicted not going to treatment. So no surprise. But RMC doubled the likelihood of them going to treatment. And that's how we got our effects. When we look at who comes out of the door of treatment at the beginning of the quarter and whether they relapse and go back in the community using or go into the community in recovery, which we all care about, right? That's what we're trying to do. It turns out that the more they were using during treatment and their treatment resistance predicts relapse, and that the more treatment successfully engaged them in self-help, not just going to self-help, but self-help activities. Am I reading? Do I have a sponsor? Do I talk in meeting? Do I do service? Do I do meditation? Do I do the behaviors of someone in recovery? That actually matters more than going 90 in 90 days. That going to a meeting and getting a signature has a small positive effect. But doing the behaviors that everybody in self-help wants you to do has the big effect. So it's not just going, it's actually engaging. So the treatment has become very medicalized and very professional. And that has had some benefits. But linking to people to a community in recovery, when you understand that most of recovery is after treatment, turns out to be a bigger predictor of how successful treatment is. So if I go to cancer or I go to diabetes, there's often support groups I connect you with, right? I connect you with survivors or other kinds of people. We have this rich tradition, but it's become kind of fractured in many modern systems where treatment's one thing and self-help's another, and never the two shall meet, or they do it superficially. But we really have to relink that if you think of a chronic care model. They have to be reintegrated because that actually is the biggest predictor of treatment effectiveness, is how well you've achieved that. I can also look at it economically. Many of you have to deal with funding issues, getting the government to give you more money. Do we want to try something new? Who's going to pay for it? Okay? This is just the reality of our life. So we also do economic analysis, and we estimate the cost per day of abstinence achieved of recovery management checkups. It costs about $23 per day of abstinence achieved. It costs about $59 per reduced symptom of substance use disorder. Now you might ask, well, is that worth it? Well, if you think about it, that would mean about $1,300 to achieve a year of abstinence. It's about the cost of an episode of care over 4 years. And they were going to go get it anyway, so you're actually reducing it. If I look at the cost and try to look at a benefit cost, here's my direct intervention cost. Is the large part of that just follow-up, so we look at the difference. If I look at, I'm going to increase treatment, other mental, physical, things like emergency room admissions, other social service, employment, criminal justice involvement. When I add all that up and say if I've gotten a chronic care model, we often shift people from emergency rooms, hospitalization, incarceration to low-cost outpatient. That if I get them in earlier, even to residential, they don't need to stay as long, and they do better if I intervene earlier. So it's a chronic care model. Well, it turns out that over 4 years, RMC cut the cost to the system. So it actually saved $1,500 for every person you treated. So this is the 4-year cost. Costs an extra $2,100 to do RMC for 4 years. And the reduction in it was completely offset by the reductions in these other costs. So let's turn to adolescence and talk about what does this look like for adolescents. Because remember, in the brain slides, I talked about how important adolescents are. So far, I've mostly been talking about adults. Well, here's the same cycle with adolescents, except here, 48% of them change status every quarter. Okay? So adolescents are even more moving around. They move in every direction. Treatment is no panacea, but still is the best odds of entering recovery. It's not as effective as it is with adults, but it is getting there. There's 16 possible pathways. I'm not going to show you all of them. What I am going to do is just summarize for you what happens with adolescents. Turns out that when I look at those 16 pathways of moving towards recovery and staying there, that the things that are risk for not doing it are if they're older adolescents, male, Caucasian, the more substance use problems or the more they use, their chronicity or their severity, the more times they've already been in treatment, each time it's less effective, the more mental health problems they have, co-occurring illegal activity, and employment. For kids to be employed means they have money in their pocket and they're impulsive and they spend that money on drugs. So employment's actually a risk factor for kids. For adults, we often think of employment as good, but for kids, it's a risk factor. On the positive side, the earlier you get there. So if you put substance use screening and intervention into schools, not waiting for them to use for 20 years before you intervene. If you go out and reach out to them, it matters. Females and minorities actually are more likely to go into recovery than Caucasian males. Recent treatment, the fact that you're following up on somebody who's coming back into the community. Treatment, when somebody relapses after treatment, it's a very good opportunity to, if they do relapse, getting them back on the straight and narrow is easy this more recently treatment was. The more you let them sit out there and fester, the harder it is to re-intervene. The number of drug screens, it turns out that when probation or any kind of continuing care actively, physically monitors you for use, it has a positive effect. You know that you're going to get caught, that somebody's watching. Or when you do get caught, they push you back to treatment. That increases your odds of moving towards and staying in treatment, in recovery. Attending 12-step meetings, positive social peers, positive recovery environment, and school attendance. Being in school, we often in adolescent treatment rush to get them a GED to get them out in the world working. That's actually a risk factor. Whereas getting them to reintegrate into schools would be a positive factor. And yet treatment often tries to act like they're little adults and that we should just get them their GED and go out into the world of work. They're actually more likely to relapse if we do what we typically do with kids vocationally. They need to get back into a healthy school environment. Now, schools don't necessarily want them. I'm not of an illusion. But figuring that out and making a positive school environment. In the U.S., I think there's some in Canada. We have recovery high schools and recovery colleges with programs very focused on people in recovery. And they've been huge Nice, very nice effects. If I look at the percentage of people in recovery, and by this I mean no use, symptoms of substance use disorders, and that they're living in the community. Simple definition of recovery. And I look at it from the beginning of intake to 12 months. You can see this is residential, this is outpatient, this is continuing care. Residential is serving more severe kids. That's what it's supposed to do. Over 12 months, outpatient and residential both get better, and they stay kind of parallel to each other. At the end of residential, they're just sort of where the outpatient is, which is why we often say step down. Okay? The one that's radically better is post-residential or post-treatment continuing care. That doubles the outcomes. This is the thing I told you that we only do 17% of the time. Anything. Continuing care, community reintegration. Yes, you have to get them to stop, but helping them reintegrate into schools or communities, that's really what doubles the outcome. Not how long they stay in treatment, not necessarily all the treatment service characteristics, but that community reintegration is what doubles it. Turns out it's also cost effective. If you do it and you see big benefits because you're improving, treatment was already cost effective, so if you double its effect, you're going to make it more cost effective. So if I take out the cost of the continuing care and look at those savings, regular continuing care saves about $4,800 in 12 months. But if I put in contingency management or I put in more assertive continuing care, I can save over $10,000 per kid, right? The interesting thing is that if I overload the kids, I don't get the price. This is the price point. If I keep adding things, I don't really get a return on investment. They get overwhelmed if I try to ask them to do too much. So you have to find something you can do, balancing what's reasonable and costs, and just adding more and more continuing care actually starts not paying for itself, clinically or economically. There's just summarizing some of the other literature. Continuing care interventions have continued to demonstrate values, but often the effects of continuing care take 12 to 18 months to see. And remember, we keep studying things with 6-month rulers. So if you want to study continuing care, you have to go out at least 1 and preferably 2 years. Recovery management checkups are effective primarily for linking people back to treatment, especially who were not otherwise monitored. If you already have an intensive probation or case management protocol, there's no value of adding RMC, okay? Because it's literally doing some of the same thing. Self-help approaches are valuable, but often underutilized and realistically not always well targeted to subgroups like adolescents, or if you're gay, you may not feel like you fit in the average self-help group. So we have to improve that. Technological approaches, which I'm going to turn to now, is like the phone, using the internet, text, and more recently smartphones, are starting to provide access to more recovery support services. So let me transition now to early smartphone work. Gustafson published one of the first large-scale trials with adults coming out of residential treatment using smartphones. He showed that he could significantly reduce their heavy alcohol use in the 12 months after they came out of treatment. But there were some limits. He had an engineer talking like this in very quiet, calm, straight voice with no attention or detail, train all the clients by video. It didn't work very well. He had low-frequency self-monitoring. People weren't checking in. They weren't using the phone as much, and they weren't really checking their persons, places, and things, or any of those kinds of things. And there's low utilization of the recovery support services, about 50 times a week. And he only focused on alcohol, even though half his population was also using drugs. He was funded by the National Institute on Alcohol Abuse and Alcoholism, so that's why he focused on alcohol. So we did a pilot providing with about 50 people where we provided them with smartphones and a full account. We gave them to them we did 2 days of training and proficiency checks to make sure they understood how to use the phone. We did urine checks for the first couple weeks. We asked them to self-monitor 6 times a day, where we gave you a random prompt at a random time and said, who are you with? What are you doing? Where are you at? How are you feeling? And for each of those, is it supporting your recovery? Is it making you want to use alcohol or drugs? And we asked a few other things like, are you using, is there alcohol and drugs in your environment? Do you have craving, pain? Takes about 2 minutes, very quick. We got them to do those, this is called ecological momentary assessment when we do that. We also gave them a suite of things on their phone so they could do a meeting locator, they could do an online meeting, they could text or call or email their friends, their sponsor. They had emergency buttons that would send canned messages to them asking for help. They could listen to Pandora and music. They could play games. We downloaded the 10 most popular free games so that they could play games on their phone. We had a whole suite of things that they could do. They had access to these things 24 hours a day, 7 days. If they had any problems with the phones, we had a customer line where we would help them. The kinds of things we had on the phone, the recovery support, there were discussion groups, support teams reaching out to others. The relaxation included guided relaxation, breathing exercise, mindfulness, pain management techniques, playing games, listening to music, recovery motivation. What was your personal motivation? In the tape this morning, they were talking about what was their motivation, so we put that on their pictures, your children, your wife, your spouse, whatever motivated you, we tried to make sure it was on the phone so you could remind yourself and you could review it. We included social networking and then directly documented from the phone what they did. To give you a sense of it, so 6 times a day for 6 weeks, we were able to get 82 to 90% of the adolescents and adults to do these EMAs. We were able to document their use about 30 to 43% of the time in a 1-week period. We would find at some point they were using. But here's the really cool thing for relapse prevention. In any given moment, only about 3% of the adolescents and 10% of the adults were using. So even though we have this difference here, is the opportunity to get ahead of it and intervene at a very timely moment when they're at highest risk. The kappa, by the way, if we compare urine and self-report, 0.5, 0.6, that's pretty much what you see in any research study. So these self-monitoring, we can get them to be relatively honest. And the errors go in both directions. So this is many times where they tell us they're using and the urine's clean as the urine's dirty and they're saying they're not using. Urines are not actually that precise. They're unbiased, but they're not necessarily that precise. If I look at the time from a given EMA, when I pinged them on the phone and they told me what the risk was, to when they would next use in the next 7 days, it turns out I can actually pretty accurately predict their risk of relapse in the next 7 days. The people who were currently using said, I've used in the last 30 minutes. Over 60% of them used again in the next day, the next 24 hours. They were very likely to continue using. Of those who were self-monitoring, telling me they had some risk, some imperfect support, only about 31% would use in the next 7 days. Much different pattern, it takes longer. There's another group here which I've labeled denial, which said nothing is putting me at risk. And everything completely supports my recovery. Doesn't really happen that often. Turns out they're at moderate risk of relapse. They're in the middle. They're not actually, these are adolescents in this chart, so they're not actually accurately perceiving their environment. I can do the same thing with adults, but here with adults, I can actually get them to break out those who are self-monitoring to low and high risk, and the adults do seem to understand the difference. And the low risk are the lowest risk, and high risk are higher, and current use are current. But again, there's this group in the middle with moderate risk and denial who say, no risk, everything's fine, the sun's out, everybody believes in me, it's great. They're actually at moderate risk. So it turns out that if we then give everybody and we look at these interventions, they use lots of interventions, an average of 84 times a week for the kids and 130 times for the adults. So they're using these things on the phone, more than twice the rate. For the kids, there's actually a problem because the adults use the system. The kids figured out how to use the phone other ways, and it wasn't documenting it in the system, but we knew they were doing it, so we're fixing that for the next study. If I look at what happens for adolescents and adults if they don't use the EMA and if they go at least 2 clicks in, they've started doing something, it turns out I can significantly reduce their likelihood of relapse in the next 7 days. So just giving them this stuff on their phone and getting them to use it reduces their risk of relapse. It also interacts. If I look at their risk, those 3 risk groups, it turns out that the biggest effect are those who are self-monitoring. If I get you to self-monitor for relapse prevention and I give you these interventions on the phone, I have the biggest effect. I cut in half the odds of you using in the next 7 days. I can do the same thing with adults, although here the biggest effect is really with the people in denial and high risk. One thing to realize is denial is not a type of person, it's a moment in time. Lots of adults have times when they are paying attention and times when they aren't. So with this group, it's not like it's all one or the other. These are points in time. So in conclusion, because I'm just about out of time, and then I'll take a few questions. Addiction has immediate and long-term consequences on the brain. It is chronic in the sense that it persists over a long period of time. The risk of relapse persists, and their sustained interventions may be required to manage it more effectively and cost-effectively. The nature of addiction typically includes multiple periods of abstinence, relapse, treatment, incarceration. Movement towards treatment and recovery is to some extent predictable, and we can influence it. It's not some random event. Managing addiction via regular checkups improves the odds of achieving and sustaining recovery, and it's cost-effective and even reduces total cost to society. We're just completing a replication of RMC with women coming out of Cook County Jail. Actually, one of the studies was just published for the pilot studies with adolescents. The adults is under review. And we're currently building a 3rd generation of smartphone software to address some of the problems we had. And we just received a grant from the National Institute of Drug Abuse to do a randomized trial with the smartphones with 400 people. And we're doing the same thing with adolescents this spring. And with that, I'll stop, throw it open for questions.
So the question is about the therapists who are doing the chronic care follow-up. Are they always the same and is the fact of being the same person, having a strong relationship, has an effect on the results of this kind of
We use the people doing recovery management checkups are a team of paraprofessionals. 2 of them have master's degrees and 2 don't. They're not the counselors in treatment, and they're not supposed to do treatment as part of the continuing care. So they try to keep it separate from the formal treatment and they do that in part because we're not reimbursed to do treatment. So if they need treatment, our job is to get them back to treatment. So it's separate in that sense. We do generally try to have the same, if it's going well, we would have the same person contact you. Of course, people turn over. So within over 4 years, there's staff turnover. But within that limit, we would generally use the same person if it went well. If it didn't go well, we would switch. So, in Therapeutic Alliance, if it's not going well, that's a bad predictor. It's kind of an interesting thing. Most people don't think about it, but why don't we switch? If it's not going well, why don't you switch? Well, we do. If you say, if my relationship is going great, I'll take them again, great. If it's not, we give them to somebody else the next time. So we would switch it up and to break the cycle if there's a negative pattern going on. We use that strategy. In the back page, there's a reference to an article by Chris Scott and colleagues, myself, from 2011 American Journal of Public Health, where we looked at the time to relapse, or time to death. And we showed that the duration of abstinence predicted reduced death. But so did the percentage of days that they were abstinent. It isn't one or the other. Both matter. The more days you were abstinent, the better. And the longer you were continuously abstinent, it was better. It's often set up as one or the other. But there is some value to harm reduction, and there is some value to continuous abstinence. And if you have both, it's going to be better than either one alone. Okay? So we use harm reduction when we would first rather that they go to treatment or go to self-help. We would rather they stop. But if they won't stop, we'll try to get them to reduce their use. It's a descending priority. You know, reduced harm reduction is better than nothing. But if I can get them to stop, I would rather them stop than go to harm reduction as my first response. It is what you said, that the data suggests very clearly that, and I'm going to use a broader word, fellowships matter. There's not a lot of data that AA versus NA versus CA versus rational recovery. There's very little data that one of them is radically better than the other. And I would actually even broaden it to say, if you've got a Faces and Voices of Recovery or Youth in Recovery or other kind of recovery group, connecting them to communities of recovery is what matters. And fellowships are the easiest, best established way to do that. But if you have other communities of recovery that you can access, like recovery high schools or colleges, those are great. It's what you're doing, but fellowships are the biggest single source of people committed to doing that in most communities. So to not link to them is kind of insane. But we do it often superficially. We'll say, oh, here they are, here's a list. But in reality, most people have to go to several different meetings and see where they connect. It's partially establishing a relationship with a sponsor or the schedule, or finding, like, if I'm a teen and I'm in this room, can you imagine what a 15-year-old would feel like in this room? They'd hug the wall, right? And they'd be on their phone texting, why am I here? So a teen is going to care about, are there at least 4 or 5 other teens in that meeting? Same thing if you were gay or you're lesbian and you wanted to go to a meeting and there are people making sexual innuendos or jokes. You're not going to feel comfortable there. So part of it is finding less about the purity of one particular fellowship over another. You do have to find one, but helping clients negotiate how to find a fellowship or other community of recovery that helps them matters. The smartphone work I was doing was in part because that is so difficult that in some ways using technology to help them manage, because what if my craving comes at 2 in the morning? There's not a lot of fellowships to go to, and you may have a really nice sponsor who will answer the phone. But not every sponsor answers the phone at 2 in the morning, okay? And not everybody has a sponsor, and or has a close relationship with them. So having some mechanisms, whether they're fellowships, communities of recovery, structural things like continuing care protocols, recovery schools, or technology that helps connect you, all those things are good. And the more of them and the broader your array of what you can offer a client, the more effective you're going to be.
Do you have any information about how we can differentiate people who would need an acute care model or who would be better into a kind of follow-up like you proposed? Can we differentiate people with some screening or tools that would help us?
The short answer is no. The longer answer is, in theory, you could do it. But there's so few long-term studies. So Chris Scott has one going out 18 years. There's about 10 studies that have gone out 10 or more years. 10, 2 hands. There are, of the continuing care randomized experiments, of every kind, shape, size, whether it's done well or bad, there's less than 50. And some of them are very different, like telephone for 6 weeks post-treatment versus inpatient or versus a computer. They're very different from like what we were saying. So there's not enough data really to do that. One would assume, though, this is me speculating, that the more severity, the more complex the case, you have multiple problems, and the more you've already not responded well to treatment, the more likely I'm sure that you need a chronic care model. The more you're catching them early, low severity, simple problem focused, lots of support in their life, whether from family or institutions, there's probably less value to it. So that's